It's my absolute pleasure to welcome you to this ICA webinar on Wednesdays. And this particular webinar is dedicated to ECMO, which is the currently much spoken about subject in most of the medical circles. And as you are aware, Indian College of Anesthesiologists started as an offshoot of Indian Society of Anesthesiologists in 2008, being the academic body of the society, but it is being now run independent of the Indian Society of Anesthesiologists. And the hallmark of Indian College of Anesthesiologists is the Wednesday webinars, which are very popular and well attended, targeting both the trainees as well as practicing anesthesiologists. And we are grateful that today we have stars in the field of ECMO joining us for this webinar. We have Dr. Poonam from All India Institute, Dr. Vivek Gupta, Dr. Himal Dev from Bangalore, and myself as moderators. And we have listed out 5 talks. Each talk will be for about 14 minutes, and the discussion may be at the end of each talk or at the end of the session, depending upon the availability of the particular faculty. And hence, I request you to post your questions on the chat box, and your comments are as well may be posted on the chat box. We will read them out at the end of the session to the extent possible. And with that short introduction, once again thanking you for joining us for this webinar. I request Dr. Poonam Malhotra to take over and introduce the speakers one by one, and then carry on with the session. Thank you so much. Good luck.
Thank you, Dr. Muralidhar. It's indeed this pleasure to have a galaxy of ECMO intensivists from different parts of the world, all of Indian origin, join us. The idea is, when we met at SWAC also, to have something which is Indian in flavor as well as international in taste. And I thought probably one of the few best talks of that session. I requested the authors, please join us for our anesthesiologists on Indian soil, because today ECMO is the next stethoscope in every ICU, not just cardiac, but neonatal, pediatric, even gynae for PPH. We have so many, at least names. Trauma is a very upcoming subject, and many patients on toxicity and toxicology. My colleague, Dr. Vivek Gupta, is an expert on the same from Ludhiana DMC, and each one of them, whether Himal or Rian here or Dr. Muralidhar, is from an institution which has served ECMO to the best. We are all members of the ECMO Society of India, which has paved the way. And in our own institutions, with our own small societies or big societies, so many of them are also members, so many of them are the ECMO Central authors. And from Royal Papworth, Dr. Pradeep from Abu Dhabi Cleveland Clinic, Dr. Vivek Kakkar, from Brisbane, Dr. Kiran Shekhar, and each one of them from India. You all know all of them. It's my proud privilege to introduce them one by one. And ECMO Basic is something that I would be beginning with, and you can ask the questions at the end of every session. 2 questions are allowed. So as I share my slide, let me tell you why we as anesthesiologists need to be knowing so much about ECMO before ECMO goes on in the hands of, let's say, the cardiologists in the cath lab or the neonatal pediatricians. They are at it in a big way, or in the hands of the surgeons. ECMO is not one stakeholder's duty. ECMO is a stakeholder from many form a team. Maybe in my eyes, the backbone is a perfusionist or a nurse who's at the bedside 24/7 with the patient. So with that in view, let's begin thinking that ECMO is something that each anesthesiologist needs to know for so many reasons, and these 10-15 slides will tell you where we as anesthesiologists can fit in and do our bit to the patient and form an important team leader for ECMO. Maybe if not a team leader, a stakeholder doing good ECMO for many reasons. So at the beginning, I salute my alma mater, where I've been working for so many years, nearly 3 decades now. I salute AIMS for being the first center to begin ECMO. We've done more than 8,000 ECMO since 2002. maybe with a mortality of 70% till 2010. And then from 2010, ours is more of a arterial ECMO. We do veno-venous in the other center of the pulmonary medicine group. They do it for ARDS, but we also do VV and VA, but it's more of pediatric VA and adult VA for cardiogenic shock and heart failure. I have no disclosures. And when I think about ECMO in 2002, this was our OT. That bulky machine, a roller pump with the CPB machine, it gets detached and the patient shifts in low cardiac output on ECMO. And this ECMO was put in more to save the patient because we could not come off bypass. The heart was swollen out of the thoracic cavity and we didn't know what to think about it. Then became small, low fidelity and high fidelity simulation classes. And that's how TSS, the Simulation Society, was born, to teach on mannequins, to teach in many ways why ECMO is a modality that needs to be put at the right time in the right patient for the right indication. ECMO is a temporary support of the heart and lung function by partial cardiopulmonary bypass used for a reversible cardiopulmonary failure for maybe pulmonary causes like ARDS, cardiac causes like cardiogenic shock or low cardiac output, or a myocarditis or a heart failure. While we were doing this and teaching and training with our pamphlets, with our newsletters, with our books, we came across and collaborated with many. Our main alma mater with AIMS collaborating at that time was Mayo Clinic, Chester. From Mayo Clinic till 2010 came the integrated ECMO. And we started to use ECMO for which kind of device? The IBP was replaced by the VA ECMO with percutaneous pads paving the way, and temporary LVAD, RVAD, and BIVAD became globally available for many. Maybe we were lacking that in 2010, and bridge to recovery, bridge to decision, bridge to transplant for cardiac as well as for lung, and using ECMO as a destination therapy till a total durable VAD or a RVAD was available for chronic heart failure became the norm in many ICUs all over the world, including India. VV and VA ECMO are the two types of ECMO with hybrid configurations. VV ECMO is done mainly to replace the pulmonary function, oxygenation, and decarboxylation to allow the lungs to rest and to heal. And when we put VV ECMO for a bad lung and a good heart, we could also see that a good lung and a bad heart, we do not put VV ECMO, and neither do we put a VV ECMO for bad lung and bad heart. So you have to put a VV ECMO for two reasons. When a VV ECMO is put for a bad lung and a good heart, and sometimes it doesn't help, maybe a central VA central cannula is required. But a VA ECMO is generally done to support the heart and a good heart or a bad lung. Maybe we don't need a central ECMO, but we need a peripheral VA ECMO for a good lung and a bad heart, and a bad lung also and a bad heart. So a peripheral or a VA ECMO, central or peripheral, is generally always for a bad heart. So with that in mind, CardioHelp is one of the best oxygenators, although very expensive over the Codrox or the Euroset or the Medtronic. You have so many oxygenators which form the backbone of the patient's lung. We generally put in this for our HIT patients or those patients we are giving Bival. Our center uses a lot of bivalirudine as an alternative to heparin. Heparin is the gold standard. Maintaining an ACT between 160 to 200 seconds is our norm. Today, with low dose heparin between 1 to 2 milligram per kg body weight, this is how we come off on the integrated ECMO circuit. So this oxygenator has compartments. It has stacked PMPA siliconized stack sheets, and the blood flows through three compartment phase. There is a gaseous phase, there is a blood where carbon dioxide is removed with the presence of the sweep gas, and there is the other phase which goes as a return cannula from the oxygenator back to the patient with all carbon dioxide removed and only carrying the oxygenated blood. So you have a blender there, the Sectoris blender with the sweep gas flow attached to it. You have a good pump which is detachable from a hard case, the blue one, and you have the red one, the oxygenator that you are seeing. So inside the oxygenators are these microporous polypropylene, propylene, hollow fibers or non-microporous silicon rubber stacked sheets. These prevent a risk of embolization and allows superior control of blood gases with new generation of oxygenators like the polymethylpentene, showing and paving the way for improved gas exchange, reduced cell damage, decreased hemolysis index, and platelet transfusion also being decreased. We are today in an era of very sleek ECMO machines coming together. I wouldn't go. This is the latest ECMO oxygenators that you will be seeing. And you can see most of the 259 ECMO centers across India using the Quadrox. At least one of the rotaflows from Mecca is available in every center of ECMO today. So while we are showcasing these, you must know how these circuits work. You have a drainage line that comes in from the patient by gravity into the ECMO circuit where all the carbon dioxide is removed, oxygen added, and with this is the green one is the sweep gas. Once this is added to the oxygenator, you have the return cannula going back to the patient. This is the return cannula, and you can see this was a VV ECMO. So ECMO basic configurations are two. As I said, VA and VV. Blood is taken from the patient's vein. It could be an IJV, it could be a femoral vein, and returned to an artery, which could be, in the case of a veno-arterial ECMO, a central access like the ascending aorta. It could be aortic root. It could be the femoral artery in case of a femoral cannulation or a peripheral cannulation. VA supports both the cardiac as well as the lungs. Now, the VV ECMO, it is taken from an IJV or a peripheral femoral vein. It could be any peripheral vein. Today, there are so many modifications of the veins taken and returned always back to a vein. So you could have both the veins of the groin, right and left, cannulated from one femoral vein back to the other femoral vein, or you could go give it back to the IJV or the IVC. So what are the indications? Whenever for VV ECMO, whenever there is a hypoxic respiratory failure with a PaO2, FiO2 less than 150, while the patient is receiving more than 0.9 or 0.8 of an FiO2 with high PEEP of 15 to 20 centimeters, sometimes 8 to 9 centimeters of water suffices, but PEEP is always a good thing to prevent an atelectic lung. Lung protective ventilation or ultra protective ventilation is generally followed on rest settings for any kind of ECMO ventilation with a Murray score more than 2 and an ability to maintain airway plateau pressure less than 30 centimeters. So when you have a patient like an ARDS, like any patient who's coming with a kind of a bad lung, it could be sarcoidosis, it could be anything that's a bronchiectasis which has gone bad with asthma, where the PEEP is high and the airway pressures are not coming down, and you have a PaO2, FiO2 less than 150 with almost 0.9 to 100% of oxygen, that is the hypoxic respiratory failure where ECMO should be put earlier if possible. Bridge to lung transplant, primary graft failure of lung transplant, any ARDS is the main cause, or a hypercapnic respiratory failure indication of a PaCO2 more than 80 with a pH less than 7.9. A hypercapnic acidosis is one of the major indications where even though the plateau pressure may be between 25 to 30, the patient would need an ECMO like a status asthmaticus. So absolute contraindications remain a prolonged CPR. DNR on ECMO is the norm. Any prolonged CPR, any unwitnessed cardiac arrest, not a transplant or VAD support candidate, unprepared aortic dissection, severe AR, unrecoverable severe brain injury, disseminated malignancy, lethal chromosomal abnormalities, and pulmonary hypertension with a PAP of more than 50 is an absolute contraindication. With obesity and advanced age more than 65, 70 these days, prolonged mechanical ventilation more than 14 days, and pre-existing chronic illness with long-term prognosis is a relative contraindications. The techniques for veno-venous are very well shown in this circuit. You draw by gravity the blood from the patient. You can see from the femoral vein into a pump. The pump is the heart. This could be any pump. It's a levitated magnetically microaxial flow pump today. And this pump goes to the oxygenator, which I showed earlier, and then the oxygenated blood returns back to the patient's vein, in this case, the IJV. So you have different cannulations. The cannulation technique remains the Seldinger technique. This is the femoral vein being cannulated. Once you have cannulated with the right size cannula, remember, you should have adequate size cannula according to the BSA of the patient. The technique done should be done under all asepsis, and once done, you need to be very, very careful that asepsis is maintained all throughout. The right cannulation technique, the right asepsis maintenance, and done at the right time paves the way for good ECMO drainage, no drainage insufficiencies, no increase in driving pressures. Try to keep on ventilation, which is a rest ventilation, a driving pressure less than 12, around 12 or 10 to 12, always less than 15. And what is the driving pressure? Whenever you have a peak inspiratory pressure and you minus the PEEP from that, that is the driving pressure. So while we are doing the cannulation, I'm sure all of you know the arterial. They could be straight or curved cannulas. Very beautiful cannulas are available in the market today. They could be two-stage cannulas, single lumen. They could be a dual lumen, Avalon, or a Crescent cannula available in the market today. You must know your cannulas well. ECMO cannulation is a technique which is well mastered by the intensivist in the form of an anesthesiologist. So these are the different configurations for access and return cannulas. While the cannula is being done and the dilator is being removed, it's good to clamp at the right time. RA iota run could be there. The access cannula in the RA and the return to the iota or to the femoral artery or to the axillary artery. Now I'm talking of femoral VA cannulation or central VA cannulation. So when you come to the cannulas on the access side, it could be the RA, the femoral vein, the subclavian vein, or the internal jugular vein, with the return cannula either into the aorta or the femoral artery or the axillary artery or the carotid artery. So ECMO, while we are doing, can troubleshoot. It could create complications. There could be air in the pump. And when there is air in the pump, every intensivist, while at the ECMO bedside and with the help of the perfusionist and the nurse, should know what to do. So first and foremost, stop the entire console, stop the pump. Remove this pump head from the pump drive console, and you remove it by pressing one of the buttons on which of the hard case on which the pump is resting. So affix the pump head onto the hand crank. And once you affix it onto the hand crank, why did we remove the pump? There was clots in the pump. And nudge the pump head in well-suited side and start in an anti-clockwise direction, the hand crank to about 1500 RPM revolutions per minute. And you should know how to use the hand crank, manual hand crank well. Then unclamp slowly and watch out for all the air bubbles. While you're doing this, if no air bubbles are seen and on the hand crank, and we are doing this, also keep monitoring the position of the heart. While we are on a VA ECMO, echo becomes a very, very essential thing. Don't buy an ECMO machine in a center without a point of care bleeding machine, without knowing the patient infection sites, without knowing the bleeding norms of thrombosis or hemorrhage, and without seeing maybe a stunned LV. LV distension on a VA ECMO due to retrograde flow is a norm. And in this case, there'll be an MR which will cause so much of LV dilatation that the aortic valve will close. So short of using IBP, ECMO and IBP together can be used. Knowing principles of VA ECMO management and knowing how to do ECMO cannulation, seeing the right echo parameters, or seeing the aortic valve opening and the LVOT not being obstructed, and decompressing this LV at the right time, maybe in a child with a balloon atrial septostomy, maybe with the mean PA pressures, if they are more than 30, just an IBP will suffice, or maybe with an Impella 2.5 if the right heart 2 is involved, or a 5.5. LA or a LV venting by the surgeon in the OT or the OR. A VAPA is also the norm today with the Protect Dio cannula available. But those are advanced ECMO things. But I just want to say that progress and monitor, there'll be speakers speaking about the monitoring, monitor the daily progress with good echoes every day. So do a transgastric esophageal. We do a TE at our center every day. We do 3D TE to rule out any clot or thrombus in any chamber of the heart. While you're doing, see or monitor your IVC collapsibility, know your dimension index, and know how much is the preload and the afterload of the patient with good echoes done at all times. Teach your students and nurses and perfusionists the echoes so that they can pick it up too. Know that distal limb ischemia exists in the peripheral VA ECMO. Know that the complications of thromboembolism with sometimes AKI come in, and you may need to use with the ECMO machine a CRRT machine. Many centers will buy an ECMO machine with a rotum and a CRRT machine. Bleeding is a complication which not just happens because of heparin being a prodrug causing the thrombocytopenia and your platelet counts coming down, but also because of the rise of fibrinogen to more than 150 milligrams per liter, or a prothrombin time ratio coming down with INR to less than 1.5. And at that time, what we have with us only is an ACT and an APTT. So having a good coagulation panel of the classical laboratory parameters of point of care at the bedside with ACT and maybe a rotum or a sonoclot or a TEG is the norm today. And your laboratory giving you a backup of at least twice a day platelet counts, fibrinogen levels, PTINR levels, and preferably an APTT is the thing today. We were in a discussion about plasma-free hemoglobin. I wish every center in India today is also bestowed with the same. You may need to do bronchoalveolar lavages. Bleeding treatments are very scary, choosing and causing a circuit change very, very often. Doing left atrial drainage with central ECMO is a very, very difficult thing. And choosing the right target blood product for your patient who may just need maybe not whole RBC, but maybe a fibrin glue or a fibrinogen concentrate, or maybe loads of cryoprecipitate in lieu of fibrinogen concentrates when there is a hypofibrinogenemia, which you see with a flat epiphytum on a rotum. So when you use bivalirudine in maybe a HIT patient, we know it is costly, but bivalirudine in low dose and the right dose and maintenance with a good point of care technique seems to be a better thing for VA ECMO today across the centers, and our center today on pediatric and on adult is very well versed with using pivalodine in the last 3 years. So most of our CTEP patients come off on an ECMO, and when they are on an ECMO, we don't use heparin. We are on bivalirudine. While maintaining on bivalirudine, the only problem that we see is the development of small clots because of bivalirudine stasis when we are weaning off bivalirudine. So maintaining a low ACT at that time with a good PO2 and a good PCO2 is what is needed. And sometimes we have needed to change the oxygenator at that time of weaning, which is very frustrating to the whole team, but I think that is the norm. But know that alternatives to heparin do exist for ECMO today, and doing not just a hemoglobin, but platelet count, ACT and APTT is important. Like us, every institution should have these algorithms in place. The point of care algorithms with the use of point of care testing, these are all patented by us. And I think following institutional algorithms by using the right thing at the right time and giving the right product saves many re-explorations and saves many lives. So to summarize, managing a patient on ECMO requires a thorough understanding of normal and abnormal cardiopulmonary physiology. ECMO system is used to replace most of the heart and lung function, maintaining normal systemic physiology while the damaged organs and are recovering. And the ability to understand ECMO is very easy in the right hand at the right center. Do encourage each one of you to put yourself in the right conference and come to the right center with a good fellowship under your banner to learn from the people who are doing it for some time. So this is our journal, which has come out with at least 3 issues of ECMO, and we deal with a lot of patient blood management issues. Those are some of the books written last year. Thank you all.
Thank you, Dr. Poonam, for that excellent review of the basics of ECMO. You dealt with types of ECMO and the management, and you also mentioned about the complications and role of bivalirudin in certain cases. Please stay back till the end of the session, and I also request you to introduce the second speaker and carry on with the session. Thank you so much for joining us.
Thank you, Dr. Muralidhar. My next speaker for this interesting ECMO panel is Dr. Vivek Kakkar. He is a senior consultant specialist at Cleveland Clinic, Abu Dhabi. He is a senior consultant in critical care and deals with a lot of cardiac critical care and ECMO patients at his center. Cleveland Clinic is known for the ECMO being par excellence in UAE. And he will be talking to us today about my patient with diffuse alveolar hemorrhage needs ECMO. Is anticoagulation-free ECMO feasible? Over to you, Vivek. We'll take Vivek's questions at the end of his session.
Thank you very much, Dr. Poonam, for the kind introduction. I feel a great privilege in joining here as a faculty amongst legendary teachers and mentors. Um, I work currently at Cleveland Clinic Abu Dhabi, as Dr. Poonam mentioned. We have a comprehensive cardiothoracic critical care, transplant, and ECMO service. And I speak to you today sitting right here because I'm on call. And before I start, I wish you a very happy Holi to all in the audience who celebrate Holi. Um, so I think without wasting more time, the topic I've been given is one of the hottest topics, not the diffuse alveolar hemorrhage per se, but as you also heard in Dr. Poonam's talk, that bleeding is a major consideration in all patients on ECMO. And the current hot topic is whether anticoagulation-free ECMO is feasible. And what I'll try to do in the next 10, 12 minutes is situate that in the context of one particular scenario where this question comes up, i.e. diffuse alveolar hemorrhage patients who need ECMO. I gave a version of this talk at the recent SWACLSO conference. I have no conflicts of interest to disclose. And the learning objectives will give you, since we're talking about diffuse alveolar hemorrhage, we'll speak a bit about what diffuse alveolar hemorrhage is, how ECMO comes into play in patients with diffuse alveolar hemorrhage, and the feasibility or the challenges of anticoagulation-free ECMO in DAH. Now, I think you all probably familiar that diffuse alveolar hemorrhage is a very heterogeneous pulmonary syndrome. It's a rare condition, but it's life-threatening when it happens. And the mortality reported in the literature varies, and it varies because actually the reports have come through case series and case reports, and the underlying etiology varies so widely, and that impacts the outcome. So some series have reported 80% mortality, and others as little as 10%. Most often, you'll find these patients present with a triad of acute respiratory failure. They will have diffuse pulmonary infiltrate on the chest X-ray and anemia. And why anemia? Because as the name suggests, they will have a widespread extravasation of red blood cells in the pulmonary alveolar spaces. And yet, you'll be surprised that about a third of the patients do not present with hemoptysis. That happens a little bit further down the clinical course. And quite often, and especially the immunological ones, present concomitantly with the renal involvement. We used to call them good pasture syndrome, and we no longer use that term anymore as we are moving away from eponymous syndromes, and it's just called pulmonary renal syndrome. Now, if you look at the underlying pathology, you can neatly divide that into immune-mediated and non-immune mediated, with actually vast majority of the cases being immune-mediated diffuse alveolar hemorrhages, whether it is ANCA-associated vasculitis or a systematic lupus erythematosus anti-GBM antibody syndrome. However, you also have to bear in mind when you run the exhaustive panels out that there are conditions that can actually. I have had patients with severe left heart failure who've had diffuse alveolar hemorrhage. You can also have patients with idiopathic pulmonary hypertension or simple ARDS patients who develop AV malformations widespread and they bleed. And patients with bone marrow transplants, actually, those ones on immunosuppression can also have diffuse alveolar hemorrhage. So what's important is for you to take a detailed history when you go, either you're doing a pre-op assessment or you're admitting them on ICU. What is their medication history? What is their past medical history? Any signs of rheumatic, features like rashes, bone pains, prior pulmonary hemorrhages. What is also important is to work with your rheumatologist and immunologist to order an exhaustive panel of antibodies. So not just you're diagnosing this as an immunological DAH, but also neatly able to distinguish between an ANCA-associated and non-ANCA-associated vasculitis, because that has an impact on the prognosis, maybe not on the management. Now, if you do the CT scan and X-ray of these patients, what you'll often find is diffuse ground glassing, as you can see in this CT scan. This is actually a milder presentation of DAH, but you will see diffuse ground glassing, alveolar consolidation, and generally there is a left in the upper lobe sparing in these patients. And one of the pathognomonic signs is when you do a bronchoscopy and you do a distal pulmonary lavage, every successive sample that comes back is equally bloody as the first one. Unlike other sources of hemorrhages, where it starts to dilute and become lighter and lighter, in this case, actually, that isn't the case. Now, most centers are now moving away from doing a lung biopsy for confirmation of the diagnosis. If patient come with a pulmonary renal syndrome, you will probably do a renal biopsy. But most often, if underlying pathology, should you be doing a biopsy, you will find one of the three patterns. There is the most typical one where there is a pulmonary capillaritis or vasculitis. So the alveolar capillary wall just necroses and it starts bleeding heavily. In other cases, there isn't such an evidence on biopsy, and those ones are called bland pulmonary hemorrhages. And then non-immunological conditions like diffuse alveolar damage, cytotoxic therapy, they're actually none of this is relevant there. We don't really understand the mechanism. The good thing is, whichever shade of presentation these patients have, the management remains the same. You will do an induction immunosuppression with steroids. You will, you may use cyclophosphamide or mycophenolate, IVIG or Plex, and then you will maintain them on a period of immunosuppression. Some patients will have recurrence after stopping the immunosuppression, so they may need lifelong immunosuppression, and there will be some disease-specific management as well. So if you have antiphospholipid antibody syndrome, those patients will also need anticoagulation, which complicates the discussion that we're having just now. Where does ARDS come into this? I mean, I think I don't need to explain to you looking at the radiological picture I showed you. Most often the ARDS is early and more diffuse the alveolar hemorrhage is, the more severe the ARDS is. And that's generally the early ARDS. And as you can imagine, these patients get a lot of immunosuppression and they get a lot of potential sepsis or breakthrough sepsis second or third week. And that is the late ARDS. We're probably focusing on the early one here. There is no reason, although the Eolia and the Caesar trials did not have patients with DAH, but there is no reason why you should not manage them the same way. And this, the latest also algorithm suggesting the management of these patients that Dr. Poonam also kindly shared, focusing on prone positioning, ventilator synchrony with sedation or paralysis, conservative fluid management, and then proper patient selection for ECMO. I would like to emphasize that there is evidence that patients with diffuse alveolar hemorrhage, although they may not have a typical craniocaudal distribution of the disease, they do respond to prone positioning. And one thing to bear in mind is that not to keep delaying making them dry, especially if they're present with the pulmonary renal syndrome, doing an early CRRT, because that may often make the difference between needing to go on ECMO or not. Now, as I said, most of the cases, experience or the knowledge we have of DAH and ECMO comes through isolated case reports and small case series. And in 2021, actually, this group did a good job of collating all of that data available. And there were about 50 published reports of ECMO. And this is just ANCA-associated vasculitis, so bear that in mind. We're probably missing a few case reports, sporadic case reports of other cases. And a lot of that doesn't get reported because case reports are increasingly less accepted for publication. So the most common pathology was GPA, which is granulomatous polyangiitis, which we used to call Wegener's. And as I said, we're moving away from eponymous syndromes. Then was microscopic polyangiitis, and this eosinophilic granulomatous polyangiitis, which we used to call Churg-Strauss, if you remember. And there were 38 ECMOs in total. Majority of them were VVA, as you can understand. Some of them were VA. There was one venopulmonary ECMO as well. And the median ECMO duration was around 10 days, which is encouraging in terms of the topic that we're discussing, and I'll show you why. And the mortality was only 10%. So you can see actually how the patients, and this is a self-selected group. Remember, all the patients that perished without ECMO, we don't know yet. And the mortality is quite high in those groups. But ECMO can make a life and death difference in this group of patients, because it responds very well to immunosuppression. And all you need is time for patients to survive that level of hypoxia. And 50% of the patients received ECMO without anticoagulation. Surprisingly, those who received with anticoagulation, without anticoagulation, had the similar outcomes as well. And since then, there have been many more reports. I was looking at the PubMed, and many more reports with actually crazy 3 cannulation without anticoagulation and with good outcomes as well. Now, anticoagulation-free ECMO in DAH, yes, it is feasible, or no, it's not a settled status amongst the ecmologists at this point. And there's reasons are multiple actually. One, because the diffuse alveolar hemorrhage itself is a very varied pathology. You have ANCA-associated vasculitis, where we know, as I said, there's a fibrinoid necrosis of the alveolar capillaries. So there is actually a hole in the alveolar capillaries which is not going to stop bleeding till you've taken care of the inflammation. But then you also have other conditions like CHF patients who have alveolar capillary membrane rupture from high hydrostatic pressure. Some of those could be on dual antiplatelets because it could be ischemic cardiomyopathy, or it complicates things in different ways. And then we don't even understand how the bland and the drug-induced DAH cause this bleeding in the lungs. We don't really understand. So that really makes it tricky. But I want to emphasize that we've gone to great lengths in stopping bleeding in these patients. IR embolizations, use of TPA, factor 7A, intrapulmonary IV, to stop this bleeding. So the bleeding in these patients is not a joke. It does really kill. To add to the complexity, we also have the challenge that we are still really starting to understand better, but not fully, how the ECMO patient on ECMO really interact. Now, Dr. Poonam spoke at great length about the bleeding complications, the management, the protocols, and definitely our understanding of hemostatic pathways is much better. But our search for the holy grail for which is the best anticoagulant molecule, what is the best monitoring target, what is the best anticoagulation protocol, which is the best bioinert circuit. Our industry partners are working day and night as well to get us the best circuit, which causes the least amount of activation. But we don't have that at this point, or an agreed consensus on this at this point of time. So if I give you a snapshot of what's happening at this moment, looking at the ELSO registry data, we know that 40% of the patients who receive ECMO, and this is the registry data, so I make no, kind of take that with a pinch of salt, that this is a very unselected group of patients, a very heterogeneous group. 40% of the patients will have one or more bleeding or thrombotic events, and 20%, so 1 in 5 patients will have both bleeding and thrombosis. And I'll show you the next slide, it become clear actually why this happens simultaneously. And we know that while the bleeding, thrombotic patients, thrombosis is more common, is the bleeding that kills the patient. So bleeding is a significant consideration in patients on ECMO, whether you're choosing anticoagulation, to anticoagulate or not to anticoagulate. And if you look at the latest ELSO guidelines on anticoagulation, they have acknowledged the fact that you can do this without anticoagulation, but they do not want to commit to it yet because there isn't a high quality evidence to support that situation. So it leaves us none the wiser in terms of what we're supposed to do when you have a patient who's bleeding, whether it's DAH, polytrauma, or whatever else have you, with regards to anticoagulation. Now, the challenge is that when the patient is on ECMO, on one side, you have a strong immunothrombosis. So you have an activation of your immune system as well as the thrombotic pathway, and then the hemolysis. And both of those, all of these three things feed into each other. And we know that when you systematically look in patients, now this registry data reports complications when they happen actually after the fact, but we know from the studies which have systematically looked for thrombotic complications as simple as a DVT, we know that at least 50% of the patients will have DVTs after VV ECMO if you're systematically looking for it. Yeah, and these are patients who were on anticoagulation. And amongst the case reports I was looking that had reported DAH on VV ECMO, within a 7-day run, many lost circuit, they had IVC thrombus. So it's a serious issue despite anticoagulation. But there is the other side as well, that whether you anticoagulate or not, actually, this immunothrombosis will continue. At some point, you are going to run out of clotting factors, the fibrinogen. So a DIC-like picture will set in. And we know that the mechanical shear of the ECMO circuit untwists the large polymers of von Willebrand factor, so you get the required von Willebrand disease. We know for reasons that are not fully understood why the platelets start not the platelet count not just drops, but the platelet function actually deteriorates on patients in ECMO. So, which is no surprise that even when the patients receive ECMO without anticoagulation, there is a significant amount of bleeding that happens. Now, I can only surmise that it is because in the absence of anticoagulation, the left side of this pathway is even supercharged. So you have even more thrombosis and even more faster consumption of coagulant factors, and that's probably why you have serious bleeding. So it's not you cannot reassure yourself that you're not giving heparin so the patient won't bleed. Because if it runs a little bit longer, you may run into problems with bleeding, and then you don't know actually what's causing what. Is it the DAH that's bleeding still, or is it because you're running out of clotting factors in the platelet, and that's why it is bleeding? And we see that frequently when we run our ECMOs without anticoagulation, the cannulation start bleeding, which was absolutely fine. They're walking every day, and then suddenly they start bleeding. They start having a epistaxis or GI bleed. And the only reason you can see is fibrinogen has plummeted and the platelet counts have plummeted. So the challenge is then complicated also by the fact that whatever studies that we have, they haven't used so far standardized definition of what minor major bleeding is, standardized definition of what an oxygenator failure is, standardized protocol for looking for thrombotic complications. We still don't have any randomized studies. And obviously, we have to separate VV, VA, and VP separately to look at actually what the real risk in these modality is, and short run versus long run. Most of the studies still don't report actually, if you have three different systems running, you cannot say the CentriMag, CardioHelp, and Rotaflow all will have similar rate of shear flow or the quality of the blood trauma that happens through their oxygenators. So you also need to account for those factors. And lastly, we haven't. There is the tendency in the publicly funded systems to kind of be a little bit more nonchalant about, oh, we'll just change the ECMO oxygenator. We'll just run it without heparin. But actually, when you're doing the billing first and then changing the oxygenator, it becomes a factor actually. And when your ECMO oxygenator is 30,000 pounds or 25,000 pounds, it's not a small decision to make to change an oxygenator. So I think we also need to because most of the studies are done in the Western world, publicly funded system, I think this thing kind of misses the point. It's relevant to our audience today, who probably deal with the cost implications a bit more. There are a couple of trials that are currently ongoing. I think the one on the top run by Eddie Fan and group in Toronto, I'm really looking forward to. They have standardized the definition of what bleeding will be classified as thrombotic complications, oxygenator failure. So I think we'll have to wait and see. Uh, I want to just quickly take 1 minute. Actually, I came back from SWAC also, and the very next day I had a patient with diffuse alveolar hemorrhage. Patient who had had 2 episodes of DAH in the past, and he had exhaustive immunological workup. Actually, nothing blipped on the radar as to why he was having them. And he started with a relatively, actually, I wouldn't call this a severe one, although the CT looks horrific. It didn't really start with that, but actually he had big bout of hemoptysis. We intubated and went on VV ECMO rapidly within the amount of 4 hours. And I did a bronch, and actually I knew straight off this was a very bad one, because after these clots were removed, the bleeding just wouldn't stop. Yes, so we kind of packed and we said, you know what, nobody go in again for a few days. Let the immunosuppression work. We started induction chemotherapy, but he bled like crazy from all quadrants, and this was the X-ray just within 2 days. We did in selective angiograms, empiric embolizations, put TPA, put tranexamic acid, nothing doing. So much so the bleeding was so bad that we had to actually disconnect him on the ventilator, have an endobronchial balloon, just kind of tamponade the thing. The sad thing is that he had an idiopathic pulmonary hypertension with suprasystemic pressures, and now with this situation, he was deemed not a lung transplant candidate, which he was being worked up for. And he had been reluctant to get it done, so I think he kind of missed the workup. He wasn't listed. Now with the pulmonary pressures being suprasystemic, there was no chance once this bleeding happens for it to stop, because despite on high doses of treprostinil, we weren't able to bring his PA pressures down. Unfortunately, the patient passed away. And just to emphasize that these patients, when they get sick, the bleeding can really get completely out of hand. To summarize, then, obviously, I want to emphasize that DAH is a life-threatening emergency. It actually responds to ECMO very well, but it can very well, be uncontrollable and have a very high mortality rate. If you identify that early, and you start early strong immunosuppression, good evidence-based ARDS management, including VV ECMO, these patients can actually have good outcomes. You can do anticoagulation-free ECMO, VV ECMO at least, but I can only say with conviction for short runs, because we do that routinely now. Short runs, VV ECMO without anticoagulation, 5 to 10 days. I cannot say beyond that, feel comfortable saying, or recommending it. The true incidence of bleeding and thrombotic complications with longer run of ECMO, we don't know yet. So I think that's something that we need to wait and see. Thank you very much.
That was indeed a very, very, very exhaustive and a very nice insight into anticoagulation-free ECMO. You said more about VV ECMO, and you beautifully showed the video of this patient. But I just want a small, quick question from you. what bioinert material coating circuits do you use? What are they coated with? I mean, they're soft line, they are heparin coated. Is it beyond that with some other coating? So that
No, Dr. Punam, I think we use the BioLine coating because we have Centrimag and we have Rotaflow and Cardio Health, but actually bulk of our ECMO is on Cardio Health because we keep our Centrimags for temporary LVADs and RVADs. So most of our circuits are BioLine coated. And actually, even for our HIT patients, we are using that because actually that heparin is not really as accessible to the systemic circulation. It's just bonded with albumin, as you know, the BioLine coating. And actually, I was the one on the other side. I was the last wicket to fall for this anticoagulation free in our team, and I've been quite encouraged by. In fact, we have had patients for 4 months without heparin on ECMO, and not as many circuits as you would hope. But having said that, they did end up having other complications like really calcified IVC thrombosis, DVT, IVC thrombus, PE. So thrombotic complications happened, but we didn't lose as much circuit, I would have to say, without heparin.
probably a nitric oxide coated circuit would be the best, awaiting the same from the animal to the human trials and into the markets. But short of that, until we have that, I think the cost of these circuits is what defers most of us from
Correct.
using it. And we succumb to heparin. And I think in an era where you have oral anticoagulants coming on in a big way, in COVID, we use low molecular weight heparin. And sometimes only a single dose and a VA ECMO suffice
Yes.
for a ARDS patient who had some cardiac problems too. And we saved that patient. Some 8 patients were saved out of 48 that we put on ECMO. So it was a very dismissal performance on the second phase of COVID. But at the same time, while you are using an alternative like low molecular weight heparin or bival or maybe agatroban, there are many centers who use in the cath lab for PCI agatroban. I saw one cardiologist give just rivaroxaban because ECMO was put only for a day. And an oral rivaroxaban was an insight, and it was, everyone was doing round the clock coagulation profiles. He was a VIP. But at the end of the day, we don't, and we can't dare to report a single case of a VIP. But you will be seeing oral anticoagulants and a lot of more, maybe some regional citrate like CRRT
Yes,
would be the
yes,
norm.
and I think
So
But
that also
there are
is
certain
one.
yes,
reports, ma'am. People are using inhaled nitric oxide. There are few case reports now we have. There they you run the ECMO for even for a week's time
yes, very
without
right.
coagulation. So
Yes.
I think probably that will be a future, as you said rightly, that there can be coating of nitric oxide or even inhaled nitric oxide because that can help us to prevent even RV failure,
Elsa's working
which
on
is a
it. I know
common
Dr.
problem with the VV ECMO, if it's going to be prolonged one.
Very right, very right.
Yeah.
Any take from anyone else? Anyone in the
Yeah,
audience has a
one
question for
quick
Vivek?
question from me, Muralidhar here. Dr. Vivek, excellent presentation, very engaging presentation, in fact. I just would like to know whether in your case, inhaled tranexamic acid would have worked. The patient was bleeding in the chest, in the lungs, and we couldn't save him at the end.
Yeah. So, Dr. Murli, good question. I gave IV tranexamic, I gave nebulized tranexamic, and then I was so frustrated, I instilled 20 mils of tranexamic acid. Then it didn't work. We instilled factor 7A in the problem was also, I think the bleeding was coming from all quadrants. And once the clots were there, the reach of these agents there, was not there. And we also did selective, even though they could not identify a spot, they still went ahead and embolized empirically the bronchial, and still the bleeding did not stop. So I think what didn't help was the PA pressures were almost 105. Even after maximum treprostinil, they only came down to 94 PS systolic, and that did not let the bleeding relent. I think in my view. Yeah.
Sure, sure. Thank you for the clarification.
Are there any more questions in the chat? If none, then thank you, Vivek, and thanks a lot for taking your time out. And
Thank you so much.
we hope you a very safe journey there in Dubai. Keep the peace on. All the best to
I
you.
hope so. Thank you very much, Dr.
Thank you.
Punam, and thank you very much, Dr. Murli, as well for the invite. Thank you.
Thank you. Our next speaker today is a global lead in research in the ELSA world, a senior intensive care specialist from Brisbane, from the Prince Charles Hospital, Dr. Kiran Shekhar, a man multifaceted in his approach to life and a person whom I think every Indian would be very proud to imbibe, because he's a man who is not the ELSO lead for many research, not just during COVID time, but also today with ECMO Central Adverse Events. If you just punch in Kiran Shekhar, you'll see the number of publications that come on. He's a professor at the Queensland Hospital. He is associate professor at another university, the Body University. I could go on and on about Kiran, but I think it's time that we hand over the mic to him when he speaks to us about how to dose drugs on ECMO, the PKPD, and the rest. Over to you, Kiran, and thanks for joining so late in the night for us. Thank you.
My pleasure, Poonam. You are too kind. I'll just share my screen and we'll get started. Can everyone see me?
Yes, the screen has yet to come.
Okay, can you see it?
Not yet. I think the share
Okay.
button.
Yeah, now we can see.
Yes.
All right. Sorry, I
Full screen.
had a long
Yep.
day.
you.
Sorry.
Thank you.
Good evening, everyone. Of course, I can't see all the audience members. Poonam, thank you for having me and Dr. Muralidhar, and nice to see some of my friends also chairing the session. And even though I can't see you, the participants, I wish you all happy Holi. And then to get on to the topic, look, the very fact that we are asking this question, drug dosing and monitoring on ECMO, means that we are worried that ECMO does something to drugs. Before I say what it could do, just declare my conflicts. Nothing major in relation to this topic. So let's move on. Yeah. So the very fact that we're asking question of does ECMO does something to pharmacokinetics and pharmacodynamic means ECMO is potentially able to be a modifier when it comes to drug dosing. We know in critically ill patients, we see a lot of alterations in pharmacokinetics and pharmacodynamics, predominantly driven by capillary leaks, volume redistribution, organ dysfunction, especially renal and hepatic dysfunction. So we have been historically told that critically ill patients need different kind of dosing, and which is indeed true. Of course, most of the drugs we use have been tested in healthy volunteers and in people who are not that sick. So when we use these drugs in ICU, clearly we make adjustments for critical illness. And patients who often, not often, always, who go on ECMO are very critically ill. So the concern always was, does ECMO make pharmacokinetics further worse on top of what critical illness does? These are some of the common alterations we all know in critical illness. There's increased volume of distribution, decreased clearance typically, and different drugs are affected differently based on their physicochemistry. And then the question is, on top of critical illness, if we add ECMO, does the pharmacokinetic alterations get even worse? At least that was the question 20 years ago when we started doing ECMO, and that's when I started my PhD on the topic. There was a huge concern then that drugs were all sticking to the circuit, and the circuit was a black hole sucking up all the drugs, and we were worried that the patients may be getting inadequate dosing. At that point, I had to go through 10 years worth of work with incrementally dissecting out this problem. So we started what's called ECMO PK project in 2013. We started off from the basics. We looked at how stable drugs are at room temperature. Just put the drug in a known volume of blood in a container and see what happens. Drugs can just sit there externally in a vial and disintegrate. So we don't know sometimes what we are giving to our patients. So we check for the stability of drugs. We then spike the circuits with the drugs and see how much drug is lost in the circuit. These were all early. This is around 2013, as I said. We still use the quadrox oxygenators then. What we did show was drugs based on their chemical properties can stick in the circuit. So some of the drugs were significantly sequestered. Of course, it's an ex vivo circuit. The clinical implications of this could only be found out when we do more in vivo experiments. We also found that protein-bound drugs were more prone to being sequestered in the circuit. Then we had to take it to the next level and see what happens when ECMO is placed in a healthy animal. Of course, we couldn't do it in a healthy human being. So we had to find sheep, and we did it in sheep to see what effects ECMO has in a healthy sheep on pharmacokinetics. We then incrementally added critical illness. So we now then put sheep with ARDS on ECMO and gave them a known quantity of drugs and did some pharmacokinetic studies. After doing all that, essentially we had ex vivo circuits, we had healthy sheep without ECMO as controls, then we had healthy sheep on ECMO, then we had sick sheep on ECMO. By doing all this and studying pharmacokinetics in all of these different groups, we were able to figure out the independent effects of ECMO. And what we found was, once again, the independent effects of ECMO were not any more than what critical illness would usually cause. So, to say it the other way, the independent effects of ECMO on pharmacokinetics was pretty limited, actually. It was critical illness that was making the biggest difference on pharmacokinetics. So, even though we feared a lot, clearly we established that the independent effects were minimal, but then they are sheep, sheep are different, human beings are different. We had to then go and do pharmacokinetic studies for around 18 drugs. This was an international multi-center study, started in 2012, and we finally finished it and published it. It took a while to recruit, but what we found was the shaded areas represent target concentration. These are all different antibiotics, as you can see there. So we could show that for many antibiotics and other antifungal agents, um, despite adequate dosing based on various factors, we still couldn't attain target concentration in many patients. But then we went on to do more focused PK/PD studies in individual drugs. For example, meropenem here, we could show that when we, depending on creatinine clearance, when we dose them adequately, standard dosing was enough. Similarly, we showed that for, I think, this was ceftriaxone. Once again, standard dosing was shown to be enough. We went on to do the same thing for piperacillin and tazobactam. We could show that standard dosing, just like we do in critically ill patients, was enough. Similar story for ciprofloxacin. So drug by drug, vancomycin was similar. So what we established was that overall, through this whole journey of ex vivo, animal, and human pharmacokinetic studies, we could establish that the independent effect of ECMO on pharmacokinetics is pretty limited, especially with the modern day circuitry. Um, the effects are pretty limited. Even otherwise, contrary to what we thought at the start, the circuit can only hold on to so many drugs. Once the binding sites are saturated, it's not that it's sitting there sucking all the drugs. So what finally we came up with the recommendation that we can dose based on what we normally do in critically ill patients. We don't have to do anything more than that. Of course, therapeutic drug monitoring where available should be utilized. But then comes the question of looking beyond these conventional approaches, because what we've shown is that even with standard dosing, we're still not able to achieve target concentration in many patients despite availability of TDM. So what do we do with other drugs then? Antimicrobials, I did say recommend based on critical illness recommendations. For sedatives, anticoagulants, obviously, they are titrable drugs. We usually titrate them to a clinical endpoint. Same is the case for vasoactive agents. So there at least there is something to titrate to compared to antimicrobials, which you only rely on either clinical effect or even clinical effect is hard to ascertain. You have to rely on therapeutic drug monitoring. Essentially, other thing to keep in mind is the physicochemistry of the drug. If you find that you're using a highly lipophilic drug and your patient is needing big doses of those medications, just swap. For example, if you're using a lot of fentanyl and midazolam and the patient's still not going to sleep, then maybe we can switch it to morphine because it's less lipophilic, less risk of sequestration. So once we know the chemical properties of the drugs, we can slightly modify our strategy. And often with sedatives, we have to do multimodal strategies. We use a combination of opioids, oral benzodiazepines, dexmedetomidine, propofol. So sometimes instead of overdoing one class of drug, we can potentially use multiple classes of drugs. A lot of people talk about inhalational drugs. I think there's still not enough data, convincing data to say they are sustainable mode of delivery in the long term. Like occasionally in some patients, maybe, but clearly there's not enough evidence to say that is a viable route for day-to-day practice. Uh, Therapeutic drug monitoring, I know it's not universally available, but where available, we should practice it. But interestingly, despite having therapeutic drug monitoring for a drug like vancomycin, this is actually from my own center, sometimes we still get it wrong. So having TDM doesn't mean we're doing it right. We have to be very vigilant. So in the end, I think despite all the knowledge we have with critical illness and pharmacokinetics, despite all the advancements in renal replacement, and be able to more accurately predict dosing with all the software and predictive algorithms, we're still not getting it right. I think somewhere that's when we think what else could be helping us dose better. I think this is where probably the future is that AI and machine learning can probably do things better than us when it comes to dose predictions, and probably will not have to worry too much in future, and these machine learning algorithms will do it for us. And we're working on some point of care TDM tools, which may be relevant, just like we check glucose on the bedside, we should be able to hopefully in times to come have a qualitative TDM, if not exact concentrations, uh, tissue microdialysis, etc. They're all very experimental tools, but it's not something we can at least now practice day-to-day basis in an average patient. In summary, yes, ineffective antimicrobial therapy, not just in ECMO, in general, is an ongoing issue. That's mainly because there is no magic drug dosing we can do. There's a huge heterogeneity in critically ill patients. So it's not always easy to predict or get the predictions exactly right. We still need a lot of innovation. I think hopefully with machine learning and AI algorithms, we will have better dose predictions. And however, we just need, even if they come in, we still need validation in future trials. With that, I just let you guys know about this network called ECMO FarmNet. If anybody is very keen in participating in pharmacology related research in ECMO, please reach out to me, or through the website, reach out to my colleagues. We will be able to work with you and get you involved. With that, I end, and I didn't want to take too much time, Poonam. And if there are any questions, very happy to answer.
Just one question from me. Thanks for that excellent talk, Kiran. I think you told us a lot about how you struggled on the animals and came forward with these human trials, and yet we are in still a gray zone about therapeutic monitoring of the antimicrobials. What about drugs that we use on the ECMO patient, which are either lipophilic or hydrophilic, in terms of our anesthesia drugs, chiefly fentanyl and midazolam, or maybe propofol? When we use these drugs, how do you see their effect going on? Because there's this tendency sometimes not to do the neuromonitoring and not to see the kind of the BIS or the nurse value to know what drug to give when. And you keep giving the drugs, and sometimes the saturation reaches on the ECMO, especially in a prolonged ECMO, when the drugs don't work. So beyond antimicrobials, what is your experience on the anesthesia drugs that we give to maintain the patient when not awake, but in a GA status?
Yeah, look, it depends. I think something, the worst I have seen is during H1N1. I think there was something to do with the disease as well, because that's when I was really worried, and we really thought something is happening, not like it's sucking up all the drugs, because after that, we haven't seen that level of sedation requirement in recent times. And also because now I try and not sedate them at all, where possible, I try and keep them awake. So that's also partly responsible. Where possible, we just avoid as much sedation. Uh, Look, it's very hard to know. I think each patient has, what we don't know is the pharmacodynamic aspects, what ECMO does to your blood-brain barrier, what it does to, how your body responds to these medications, we don't know because there's we done some CSF studies in animal models, which shows ECMO can disrupt the blood-brain barrier significantly. So some of the some of the things we really don't understand from a pharmacodynamic perspective. There could be huge variation between, genetically varied responses between different patients. So all of that considered, I think if we are overusing any one class of drug, it's worth cycling and trying multiple agents. For example, we use ketamine, dexmedetomidine, enterol, diazepam, sometimes methadone. So you just use a cocktail instead of overdoing any one class of agents.
Kiran, Vivek here.
So Poonam,
Just
Yeah.
just one question.
Yeah.
Because recently I've come across with a study from PGI Chandigarh itself in aluminum phosphide poisoning. They are using a lipid emulsion, and how they are giving 250 ml as a bolus, and next 20 minutes they repeat it 500. And how much impact with this 500 ml will have on ECMO if suppose this patient may require a VA ECMO if not improving with the lipid emulsions?
Very
You mean to the integrity of the circuit?
Yeah,
Yeah.
because
Look, I
500 is
think
a big volume.
yes, I think this was very feared about even with propofol once upon a time. Look, it's 500 meals over what time?
Over 20 minutes means a bolus
Mm.
immediately
Mhm.
rapid, followed by
Mhm.
after 20 minutes they repeat it. So this becomes
Yeah, look.
500 ml. And as we know
Mm.
that aluminum phosphide patient if they
Yeah.
deteriorate very rapidly and may need ECMO
Mm.
very quickly within half an hour or maybe 1 hour. So
So
means
did they give it on ECMO or
no,
before
no, no. They
ECMO?
used it as a separate modality. But we are doing a
Okay.
VA ECMO in these patients, and we know that
Yeah.
even lipid emulsion, some patient may respond, but some may not respond even with that. So what will be a
So
situation?
if I understand correctly, you were wanting to know the effects of the that emulsion on the ECMO circuit. Does it affect the oxygenator in any way? Look, we did because the concern was regarding propofol. I did a little experiment, funny experiment. I didn't publish it, but I primed the circuit with propofol only, not blood, and and I put it on a bridge and just kept running it. Nothing happened. It went on for 24 hours. So, like because that was the way of me proving it to myself that if blood mixed with propofol, we are concerned, then I said, look, let's run the circuit only with propofol and see what happens.
Okay.
It was a waste of a circuit, but it was some used circuit, so I could play with it. But I think once there are a lot of unknowns because once there is a certain flow rate, um, and we don't know what happens exactly. And in an odd patient, even with a small dose of something, the circuit may pack up. But these are things where really no one knows. The manufacturer doesn't have any specific recommendations
Is
on
already
this.
answered.
Mhm.
Dr. Poonam, I have one comment, please.
Please, Dr. Vishwa, go ahead. Please go
Yeah,
ahead.
thanks for an excellent lecture, Dr. Kiran.
Thank you.
My question to you is, am I talking to Dr. Kiran? Is he there? Yeah,
Yes, he's
I
there.
can hear you,
yeah.
sir. Yeah.
We so commonly use dexmedetomidine in the intensive care unit. And would it be correct to say, because some of the literature search shows that when you're using dexmedetomidine, over a period of 24 hours, almost 80% of the drug is sequestered. So is it correct? Could you enlighten me when you're using it? So over a period of 24 hours, if 80% is sequestered, what are we left with?
This is what, before I started my work 20 years ago, this is exactly the fear we had. So it's actually the circuit's got a limited number of binding sites.
Right.
So once they are saturated, it can't absorb anything more. I've done radio labeled studies. You inject radio labeled drugs in the circuit, and you can actually do a PET scan of them and see where the drug gets attached. So it's actually doesn't doesn't absorb that much. I think one of the problems with dexmedetomidine is also, I don't know about you in your unit, but often we don't bolus it. So by the time the effect kicks in, we start at a very low dose. So it takes a while for it to kick in, and that can be mistaken as being sequestered in the circuit. So yeah, but I think for most drugs, regardless of their lipophilicity or protein binding, in a circuit experiment, we showed that there are risk factors, but then actually when you look in real world, they all cancel each other because there is volume of distribution, clearance, and sequestration. They all interact, and in the end, they all get cancelled with each other. And net effect is that we just keep doing what we're doing in critically ill patient, and it should work. Residex works very well. Ketamine works very well. Um, I think one of the challenges we had was with fentanyl, and but then we changed to morphine, and morphine got its own other challenges. Sometimes you rather use a but in our unit we try and use more of morphine. But once again, I'm not too worried about it anymore. When I started my work years ago, I was really concerned, but now after going through this journey, I'm rather assured that I think we mistake, all of the things we worry about are not something we should worry about. I think that we should do the more basic things, right? That's what I realized. We don't do a lot of the basics well, and when I say we, me included, all of us are prone to think about all the
Right.
less important things and then get the basics wrong sometimes. Yeah.
Kiran, just a question, Kiran. Himali.
Mhm.
Yes, what about the
Yeah, Himal, yes,
That's the
concurrent
last question.
CRRT,
I can see you.
ECMO
Yeah,
plus,
yeah.
yeah, ECMO plus CRRT? Is there any change from what you said? There's a concurrent CRRT running with it.
No, I think once again, what happens is there is this canceling effect, like ECMO increases the volume of distribution, decreases the clearance. So because of that, whatever clearance your RRT is providing gets cancelled to an extent. So the net effect is, you can mostly maintain target concentrations with standard dosing. And what I do is, regardless of all that, in principle, if it's a drug with wide margin of safety, especially antimicrobial, I tend to use the higher dose.
Yeah.
So things like meropenem,
Yeah.
not just in ECMO, by default in critically ill, I try and go hard. Like I use the higher possible doses because.
So
Mhm.
we were more worried about the antifungals in candidemia or voriconazole in aspergillus. There, should
Yeah.
we really worry? Yeah.
Look, once again, even if we did a pharmacokinetic study, remember in that study there were 20, 30 patients for that drug. So that doesn't mean I absolutely know what the truth is, but in the more we've done collectively, it appears like standard dosing should be enough. Voriconazole, at least we can do a level. I don't know if you have access
Yes.
to that.
Yeah, we do. Yeah.
Yeah. So at least that is taken care of, but some other antifungals we don't. Look, in the end, I think the good old clinical response should have to be looked at. Like if you think that with a certain dosing, the patient's not responding, not improving, there is no source to control.
Yeah.
There could be clinical therapeutic failure. And in those situations, maybe you can escalate the dose or add a second agent, probably.
Great.
Yeah.
Thank you, Kiran. I think your topic increased so much of questions and discussions. It is a very, very upcoming topic and something that we all fear as anesthesiologists, and that's why you did it well. Thank you so much, and thanks for your answers. And I'm sure we'll be seeing you again on the net and in also meeting soon. Thank you all. Thank you, Kiran.
No worries. Thank you, everyone.
Thank
Good
you.
night. Cheers.
Goodbye.
Bye.
So we go on to our next speaker for the day. It's none other than the father of critical care and cardiac anesthesia in a big way, the chairman of the Institute of Medanta, the Medicity for Critical Care, as well as anesthesiologist, Dr. Yatin Mehta. Sir's been a pioneer in cardiac anesthesia and then in critical care, and his work on cardiac critical care even today stands tall in terms of what he's contributed. Today, as an ECMO person intensivist, he'll be talking more on VV ECMO and acute lung injury with case-based discussions in his lecture. A proud privilege to have you here, sir. Thank you so much. And we go on to your lecture. Could share your screen with us. Thank you, sir.
Thank you.
Yes, we can see your screen.
Okay, you can see the slide? So,
Yes, yes, we can. We can. We can make
okay.
it full screen. We can make it full screen.
Okay. So, good evening to everybody, and thank you, Indian College of Anesthesia, for inviting me for this meeting, and Dr. Muralidhar, particularly, old friend of mine. Okay, so we have had a lot of discussion regarding the theoretical aspects and the safety and the basics of ECMO. Now I'm going to talk about case-based for VV ECMO, which is the commonest ECMO which is used. So this was just introductory, this thing, Dr. Bartlett is there. Most of the faces you would recognize here. We hosted the SWAC also, 2018. So this was a 34-year-old male, obese, no other comorbidities. He had a fever and cough for 5 days, breathless for 2 days, and he was treated outside with IV antibiotics and high flow nasal cannula. He was tachycardic, tachypneic, hypoxemic, on non-breathing mask. He was acidotic, PO2 and PO2 was low, PCO2 was high, PF ratio was 80. As you can see on the chest X-ray, there were bilateral ground glass opacities. Normal echo was normal. So we made a diagnosis of LRTI with severe ARDS. So at this point, would you intubate or give a trial of NIV or high flow nasal cannula or initiate early ECMO? So let's come to that. So we intubated and ventilated the patient, which is what is done. On the right side, you can see the bilateral pleural effusions, ground glass opacities. So the patient was intubated, ventilated by ARDS network ventilatory strategies, 6 mils per kilo, PEEP of 14, FiO2 was 100%, and still the plateau pressure remained high. So it was prone ventilated for 16 hours, paralyzed and sedated. PF ratio after proning was 65. And ABG was still, the patient was acidotic. PCO2 was 68 and PO2 was 55. So let's look at what are the lung rescue strategies before we put the patient on ECMO. The strongest evidence was the PROSEVA trial, the prone ventilation. Traditionally, it is done for 16 hours, but there are a few recent papers which have shown you can do it for much longer, and I do practice for a longer period of time. It improves oxygenation and mortality, and about 25% of the patients may fail on the proning, and you may consider them for VV ECMO. Recruitment maneuvers were traditionally done, but they have been now really disproved. They increase the mortality. Inhale, if the PA pressures are high on your echo or on your measuring it, then inhaled pulmonary vasodilators may improve the oxygenation and reduce the PA pressures at right ventricular afterload. APRV mode has been tried, but there is a risk of high transpulmonary pressures, and you can repeat the proning if the patient is a responder. So rescue therapies may transiently improve oxygenation, but the patient fails the proning position improvement, then obviously VV ECMO should be considered. So this patient had a PF ratio of 55 despite the proning. He still remained acidotic. His plateau pressure was more than 30, but he was hemodynamically stable. So we decided to put the patient on VV ECMO, and we put in femoral 24 French jugular femoral cannula, and jugular was 19 French return cannula. So would you call this early ECMO or late ECMO? What are the criteria? Also recommended refractory hypoxemia, PF ratio less than 80 for more than 6 hours, or less than 50 for 3 hours, or more than 3 hours. Or refractory hypercapnic respiratory failure, and patient remains acidotic, that with pH less than 7.2 despite lung protective ventilation. This is despite optimal PEEP, proning, neuromuscular blockade, and you obviously ruled out cardiac failure because the diagnosis of ARDS is established on that. Supporting mandate, but it's not mandatory. Murray score is more than 3. The respiratory score for more prognostication, and preferably a single organ failure, because the multi-organ failure, the mortality will significantly go up. What cannulation would you choose in this patient? Some of this may be a bit of repetition because it has already been covered in the previous talks. So the commonest configuration, like what we did in a patient, was femoral jugular. That means drainage venous femoral vein is 23 to 25 French, and 19 to 21 French is return cannula, which is put into the right internal jugular vein. Then you come to the femoral cannulas. Drainage is one femoral vein, return is contralateral femoral vein. And now you have a dual Avalon or Protec duo cannulas, which is single cannula into the jugular, but with double lumen. But it requires a correct positioning under TE or fluoroscopy. So where exactly these cannulas should lie, and how do you confirm the position? So this is the X-ray of the patient. As you can see, the drainage cannula tip IVC should be at the IVC and RA junction, and the return cannula should be in the mid-RA, directed towards the tricuspid valve. Okay, this is in order to reduce the mixing of the two plugs. So ensure adequate flow. We confirm in TE, and on the plain X-ray, it should be around 10 centimeter at least, the distance between the two tips. So you have a single lumen. What are the types of cannula? You have a single lumen dual cannula. A return cannula is right atrium via internal jugular vein. A drainage inferior vena cava or via femoral vein. This already has been covered. Bicable dual lumen single cannula. It should be directed to the tricuspid valve, the return cannula. And you have a bifemoral, which is both again the limited patient mobility. So this can be a problem if the PV ECMO is going to be left in for a long time. When does one do a tracheostomy? These patients, while the patient is on PV ECMO, let's look at that. Also does not specify the time when you should do the tracheostomy, but the patient obviously should be hemodynamically stable, and you expect the patient to be on ventilator for a prolonged time with a minimal vasopressor support. Coagulation is okay. Patient is not bleeding anywhere. And the commonest practice, which is practically done, is about 5 to 10 days you do a tracheostomy. And earlier you can do it if you are planning to wean off the patient awake ECMO, wean off from the ventilator, or anticipated prolonged run. Normally it's a percutaneous tracheostomy which is done, but both are acceptable, or surgical tracheostomy, but still to be done bedside in a controlled environment, bronchoscopic guided, whichever you are doing, but make sure the positioning is okay. Do not extend the neck too much, and secure the ECMO cannulas when you do the tracheostomy. So this patient, day 5 on ECMO, there's a fall in PO2, increasing delta pressure across the oxygenator, and LDH was rising. So is this oxygenator failure? What signs confirm it, and what would you do in case it is? Is hemolysis and rising D dimer a marker for oxygenated thrombosis? Let's look at that. So if there is thrombosis in the oxygenator, there is a rising delta pressure. Declining gas transfer, obviously oxygenation would be impaired. D dimer is rising. Hemolysis and clot burden as triggers, and plasma-free hemoglobin, if you monitor it, is rising. So day 6 Patient was oozing from the cannula side. ACT was about 190 seconds. APTT was 60 seconds. So how do you manage anticoagulation here? And how do you balance bleeding versus thrombosis? Unfractionated heparin to bivalirudin. Some talk has been happened about bivalirudin. I won't get into details of that. But what is the pathophysiology of bleeding on VV ECMO? Now, these are everyday bread and butter stuff which we will come across. That's why I'm discussing. You got masters of all this sitting here, and they will answer your difficult questions. So, platelet activation and consumption does happen. And there is a acquired von Willebrand factor, which Dr. Kakkar talked about. There may be heparin resistance or heat may develop. Hyperfibrinolysis is a known phenomena on ECMO, and DIC also can happen. So that is where viscoelastic testing will tell you specifically what the reason for bleeding is. You look at the cannulation site, it may bleed from tracheostomy site. GI tract bleed may happen. Upper GI is the commonest. And if the patient is post-surgical, surgical wound can bleed, on intracranial hemorrhage is a known dreaded complication. So what are your targets? ACT of around 160 is sufficient. Anti-10A, most of us do not have the facility to monitor. Platelet count to keep reasonably okay, 80,000 and above. Serum fibrinogen around 150 to 200, and INR about 1.5 to 1.8. So on day 8, there was a rising CVP, worsening lactate, echo shows dilated RV. You can see on the echo here, the septal shift to the left and reduced TAPC to 6 centimeters. Is this RV failure on VV ECMO, and how would you manage? This is again a common problem which we come across, particularly patients with ARDS with high PA pressures. So RV failure, either it was pre-existent, may get worse or may develop freshly. The pulmonary hypertension gets worse, so afterload and right heart dilates. High PV will also increase the afterload and dilate the right heart. Hypoxic pulmonary vasoconstriction is affected. Hypercapnia and acidosis makes it worse. Fluid overload may happen, maybe iatrogenic, and pulmonary microthrombi will make it worse. But they're all strong. If RV failure happens, a strong predictor of mortality. And then secondarily, you will find multi-organ failure happening. So may require configuration change. Initially, you try your diuretics and inotropes, particularly inodilators like dobutamine or milrinone, to improve the RV function and reduce the RV afterload or PAH. So you optimize your ventilator settings, reduce your PEEP if required. Pulmonary vasodilators, particularly inhaled nitric oxide, does help. Inotropes, diuresis, and CRRT can reduce the RV volume by reducing the preload, and then hybrid configuration. Add arterial limb, that means you convert it to VAV ECMO. If converted to VA, if there's a cardiogenic shock additionally, and RV assist devices in selected cases. This was the X-ray on day 11. Lung compliance was improving. FiO2 on the ECMO had come down to 0.3. Sweep gas flow, we were able to bring it down to 1 liter per minute. Ventilator FiO2 also was down to 0.4, and PEEP was down to 8, and X-ray already improving. So how would you plan weaning? Now, this is the stage I think the patient probably is ready for weaning. So let's look at the timing and what is the timing of decannulation. Patient should be, this is a sweep-off trial, hemodynamically stable and minimal vasopressors, improving lung compliance. Imaging also shows improvement. FiO2 is down to about 50%, less than 50%. PEEP is down to around less than 10 centimeters of water. Plateau pressures again has come down 25 to 28. PO2 more than 70 and pH of more than 7.3 normal pH. Okay. Then you can reduce your ECMO FiO2 in increments of 20%, reduce the sweep gas flow, and then you have a sweep-off trial. That means it's only 500 mils or 1 liter of sweep gas, And that time the saturation is 88 to 90%, PO2 more than 60, pH remains normal, patient work of breathing doesn't go up. If it fails, then you can resume your full flow and try it another time. So basically, what I'm trying to say is technology and teamwork runs ECMO, and judgment saves patients. Thank you very much for your attention.
That was a very, very nice and crisp review of the case who was having acute lung injury, sir. And I would welcome any two questions from anyone who would like to ask sir about the sweep gas, about anything about the RV failure. Any one of you. Quick two questions. I have a small question, sir. When we are coming down on the sweep gas, you said, let's say we are on 5 to 6 liters per minute, and we come down while weaning on the sweep gas trial off and we come down to 1 liter. Now, at 1 liter, sometimes it's very easy to come off, and we bring it down 0.5, 0.5, and then suddenly off. When we do it suddenly 0.5, 0.5 and off, and suddenly you see a swelling of the heart, what do we do then? And there's a question, the second question to you is from Sarvendra Verma. What is the oxygenation index?
Well, oxygenation index, basically you calculate from PO2s and saturations. So, and respiratory rate. So yes, oxidation index has maybe taken into consideration, but basically the criteria remain the same what I've said. Compliance is improved, FiO2 requirement is improved. And what you asked about the right heart dilating, once your sweep gas flow is off, basically the right heart is not tolerating. And that is a serious problem, which obviously you'll have to go back on a full ECMO flow, and you may consider going back on VAV ECMO, because obviously the right heart is not able to tolerate the coming off ECMO. But normally you will not see it, because if it is a purely VV ECMO and you have reduced the patient meets all the criteria which are specified, and then you're coming down on the sweep gas flow, patient at times may not tolerate the sweep gas flow coming down, but right heart failure is not at that stage a common phenomenon. Also continue with your dilators in a smaller dose, particularly when you're weaning off the ECMO. It's a good idea to support the right heart.
True, sir. Actually, we should look for other causes of RV failure, that why it is happening, rather than actually thinking about ECMO itself.
Rightly said. Thank you, sir. Thank you. If there are no more questions, we'd like to thank you from ICA, and thanks for giving us your time. Our last speaker and the most patient speaker is none other than Dr. Pradeep R. Madhvi Rathan from the Cambridge University Royal Papworth Hospital. He is a consultant in anesthesia intensive care medicine at the Royal Papworth Hospital, Cambridge, UK. And not just as a teacher and a mentor to many in UK, I met Pradeep, and I've been meeting him at SWAC also, and I'm very proud to say that probably his work on end of life, or his work on ECMO, is something that has paved the way for all of us here to listen who've joined today. We are lucky we are listening to one of the most patient ECMO intensivists who has very positive outcomes on ECMO. And Dr. Pradeep would be talking to us about what are the intensivist intentions in managing ECMO. I think very rightfully the last topic, what are we intensivists thinking of what to do to the patient on ECMO? And I think that's where your patience and your resilience comes in, Pradeep. Thank you so much for being with us today, and over to you for yours.
Thank you, ma'am. Can you hear me, ma'am? Can you hear me?
Yes,
Yes.
we can. You can share your slides.
Yeah. Okay. Thank you, everybody. Respected faculty members, Dr. Murali, a good friend of mine. We've been collaborating for years together. And thank you, Dr. Poonam, for inviting me to join this webinar organized by the Indian College of Anesthesiologists. And happy Holi to all viewers in India. I'm Pradeep. I work at Royal Papworth in Cambridge. I do not have any disclosures pertinent to this talk. I do want to acknowledge our director, who's kindly agreed to share some of the data from Papworth. Royal Papworth is in Cambridge, right next to Adam Brooks Hospital. We are a tertiary centre for heart and lung transplants, and we're also the only centre in the UK that offer pulmonary thromboembolectomy for CTEPH patients, and we are one of the 5 or 6 rather ECMO centres in the UK. I was asked to share this slide by Dr. Murali. I do have a few other interests, especially in medical education. I examine for the MRCP and the Faculty of Intensive Care Medicine. So I'm just going to give you a very overall sort of an overview of the role of the intensivist and their intentions in managing a patient during their ECMO journey. I think I have to say sorry because I have to repeat some of the pertinent issues that Dr. Mehta has beautifully explained already. So I want to just share some of our data from Royal Papworth. As you know, we are one of the ECMO centres, and following the flu pandemic report and the CESAR trial, NHS England commissioned 5 centres, and recently during the COVID, Aberdeen in Scotland was commissioned as a centre. So we look after East of England and Northeast London. These are our data since the inception of the service. As you can see, we have post-COVID, we have a run of 30 to 40 runs of VV ECMO. And this is not data on VA. And our outcomes around about 70-odd%. This is survival to discharge and survival to transfer to the referring center. This compares to 63% in the whole of Europe. Again, I just want to reiterate that this talk is going to be focused on respiratory ECMO or VV ECMO, particularly as our intentions in managing patients requiring VA support is quite a different entity altogether on itself. So I want to just classify our journey of the patient. Once we get a referral for ECMO, we select the patient. Patient selection and candidacy for ECMO is crucial, and not all patients benefit from ECMO. We are a service that which is matched for patients who fail conventional interventions for ARDS. This is our most recent updated criteria from NHS England. Again, mirrors what Professor Mayford mentioned earlier on. This is updated post-COVID as well. And we do consult between centers if we have any borderline patients, and we use the RESP score for prognosis. And also in patients who receive mechanical ventilation for more than 7 days, we have an individual case-by-case discussion, and we have a an MDT between centers, sometimes even more than two centers. So we examine each referral quite closely, and we ensure that all the conventional measures are exhausted before we institute ECMO, and we don't do early initiation of ECMO in the UK. So we ensure that the patients are prone at least for a few cycles, unless they've got precipitous refractory hypoxic or hypercarbic respiratory failure. And our standard approach is a FemJug config of VV ECMO, drain using a femoral cannula 25, 27, and return with jugular, as Professor Mehta mentioned, 19 or 21 returned using the right internal jugular. So intensivist intentions on ECMO are on those four areas. Firstly, diagnosis and underlying and management of the underlying problem, because we all know ECMO is not the treatment; it buys time. Unless we address the underlying problem, ECMO wouldn't be of any benefit. And also the complications that arise from either initiation or during the maintenance phase of ECMO. And ventilation on ECMO is a special interest of mine, and I just want to share some ideas and some thoughts as we go along. And finally, we'll touch upon weaning. So once we've retrieved a patient on veno-venous ECMO, this is what they get in the first 24 to 48 hours. We get a high-resolution CT with a pulmonary angiophase, and some centers do differential scanning. They do CTs with a CPAP of 5 and CPAP of 40 to see the recruitability potential of a lung parenchyma. They all get an immune panel and an infective panel, and they also get a full departmental transthoracic echo. And we are quite a proactive POCUS unit, so we do point of care ultrasound almost most days of their stay in the unit. Treating the underlying problem, rationalizing the antimicrobial therapy into immunomodulator therapy, including steroids or plasma exchange, full anticoagulation if they've got underlying Ps, and also for sustaining the extracorporeal circulation. And if there are no bleeding concerns, we do run anticoagulation-free ECMO, being mindful of the circuit. And the same basic principles of lung protective ventilation also holds for patients on ECMO. Resting the lung at a low level of tidal volume PEEP, and monitoring the driving pressure, and also monitoring the P.1, which is the patient's spontaneous effort generated in the first few milliseconds of their inspiratory effort. And also protecting the RV. I think we discussed in the last talk. We tend to use inodilators if we have objective evidence of RV dysfunction, and nebulized prostaglandins. So ventilation on ECMO, this is what we do when we get a patient on ECMO. They rest on an NFI of 0.3 to 0.5, with a PEEP of 10, a pressure control of 10, and respiratory rate of 10. So this is in the first 24 to 40 hours. This compares to the ELOIA protocol, where they recommend a higher level of PEEP, and aiming for a driving pressure of 14, less than 14, and a plateau pressure of less than 24. And we monitor the spontaneous breathing effort of the patient, and sometimes we try level best, despite our efforts. We find the spontaneous breathing quite difficult to control. By increasing the sweep gas, in most patients, we try and get control of their spontaneous efforts, thereby preventing self-inflicted lung injury, but sometimes we do struggle in preventing this sort of injury to the lung. So once, as the ECMO journey progresses, we look at the native lung recovery, including their native lung oxygenation, CO2 clearance, and we do serial imaging. Anyone who's got a ECMO around more than a couple of weeks, we repeat the CT imaging and to address any new pathologies that we can treat. So we are a unit where we did a sweep-off trial. We don't do incremental challenges. Once we are ready, we are sure that the patient is spontaneously breathing and they've got reasonable compliance and good aeration on chest X-rays or CTs plus ultrasound. We trial them off and observe at the bedside, including the respiratory mechanics and blood gas exchange. Recently, we've introduced the weaning protocol, which includes a 100% oxygen challenge test, followed by a deoxy challenge, altering the FiO2 at the blender, and then we decrease the street gas rate in incremental fashion. I wanted to just quickly take you through a couple of cases which I was personally involved on retrieval. This was a 53-year-old patient who was treated for pneumonia, quite late stage ARDS, where all conventional therapies had failed. And I assessed this patient, and we decided to go on ECMO fairly quickly. And we did cannulation at their referring hospital site using fluoroscopy, and the patient was transferred on veno-venous FemJug configuration on ECMO to us. And we do a bronchoscopy and a BAL on admission, and this patient had plastic bronchitis, which was essentially their bronchoalveolar being costed off, and had a problem with their lymphatic drainage. But this patient did well on ECMO. The run was only less than a couple of weeks, was repatriated back to the referring hospital and was discharged later. CTEPH is one of the conditions we deal with it at Papworth, and reperfusion injury is the norm. The question is how much following CTEPH or following PTE. And this was a patient who was a lady who developed quite protracted refractory respiratory failure. We had to put her on VV ECMO. We decannulated her, but then she developed 3 days later. She developed an acute subdural, so she was transferred to our neighboring trauma center where she was managed conservatively. And then she deteriorated in the neurosurgical center, and they called us again, and we went to assess her. And it was clear that she needed VV ECMO, but then because of the background history of CTEPH and right ventricular dysfunction, she did not get better on VV. So we had to reconfigure the circuit. We had to put an arterial cannula in this patient, so she had a VVA configuration, and she was transferred back to our hospital on VVA ECMO. Sadly, this patient did well and passed away a few weeks later. And one of the key things I wanted to emphasize is rehabilitation of patients both during and after ECMO, and it is teamwork. ECMO is a team game, and I'm grateful to be working with a fantastic team of ECMO specialist nurses, physiotherapists, speech and language therapists. You can see on the right side, our speech and language therapist doing a fee study, and and we have with patients with interstitial lung disease, we have a regular interstitial lung disease MDTs, and we get expertise from other teams, and it's a team game, which I quite enjoy. This is our team during the ECMO COVID surge, and as you can see, quite involved in moving patients. This is our patient who had the longest run so far with us. She spent 299 days on ECMO, and she was discharged home. We do see her in the follow-up clinic on a regular basis. She's still dependent on oxygen, but she still is alive. Thank you so much for listening, and happy to take questions. And if you want to learn ECMO with us, please, you're welcome to join us in our ECMO course. The link is on the screen. And this course can also be clubbed together with an observership at Papworth. Please get in touch with me if you're interested. Thank you very much, everybody.
Thank you, Pradeep. I think it was a very, very nice summary of the entire evening's cases done by in a very, very brief as well as compact and to the point way. It did it fantastically. And you brought about a very important part, the prehabilitation and the rehabilitation of the ECMO patient. We learned from Kiran that today, not GA, but awake ECMO is the norm. And with awake ECMO is going to be an anticoagulation-free ECMO period, at least for VV ECMO. And even for VA ECMO, we do it as a trial of during weaning, when ACTs are high, we stop the heparin infusion. And VA ECMO probably would, to my effect, with the coming of the nitric oxide circuits. And as Dr. Vivek pointed out, Dr. Vivek Gupta, that nitric oxide on the go, even with inhalation, is a very, very good drug to take care of your RV failure and PA pressure changes on ECMO. But in pediatric patients, I just have this small query. How do you rehabilitate them early? Early mobilization of the pediatric patient. I know some of your nurses, I met them during the ELSO meets, and I hear them doing pediatric early mobilization. And it's a very, very new field. It's a very niche field coming up. But the babies rehabilitating early is probably a win-win for the entire ECMO team. So have you seen them? What is your experience of it?
Dr. Poonam, I have to say we are purely an adult cardiothoracics.
Okay, wrong question.
No, it's okay. No problem.
Wrong question from my end.
No, that's right.
We're doing it. We're doing it.
I think Rian can answer that. Yes, Vivek, please.
No. I have a question. I don't have answer. Even I'm an adult intensivist and doing adult ECMO only. So two things. I just wanted to know your experience or what is your practice in Pafford. Do you do routinely bronchoscopies or once you feel that it is indicated? Because then during COVID, a lot of concept came that you do a very frequent bronchoscopies. We don't do routinely, but I just want to know about it. And how quickly you go for tracheostomy in these patients? Means as conventional, we go for fourth or fifth day or some other protocol? Because the looking at your 10 rule of 10, even I follow the same thing in spite of so many other practices are going on. I also follow the same 10, rule of 10.
Thank you, sir. Thank you, Dr. Gupta. Thank you. For the first question, bronchoscopies, we do it when we feel that there's problems with secretion clearance. We did it more frequently in patients during the COVID surge. I'd say at least 2 or 3 times a week, sort of thing. But nowadays every patient gets a bronchoscopy and BAL on the day of admission, and then we repeat the bronchoscopy when we have problems with lung aeration. We feel that there's retention of secretions, and so on. In terms of tracheostomy, about a week into ECMO, I would say. I tend to do it slightly earlier than a few of my colleagues who defer it to a bit longer. One thing I do want to stress is training pleural effusions. We don't drain pleural effusions or even a small pneumothoraces on a regular basis. Based on experience, we've had bleeding complications with chest drains, so we don't do them on a regular basis unless it's absolutely necessary.
Thank you. Thank you very much.
We do
No problem.
bronchoscopies once a week, only if there is a problem. Otherwise, we try to avoid it because if the ventilation, as rightly pointed out, is correct, why succumb to another invasive? It becomes invasive to the airways. But I think doing it at admission is the right thing. And just before you're weaning off another one is the right approach. Any other questions, please?
I think Rian wants to say something.
Please,
Rian,
Rian.
do you want to
Most
say something?
welcome. Most welcome.
I think the question was on mobilization in children. So we could actually classify them into children who are less than 15 kilos and more than 15. And if they're more than 15 or even 20, then they fall on the adult pathway where if they're veno-venously connected, if they're on a tracheostomy, they can be mobilized, or if they're on a double lumen Avalon, they can be mobilized. But less than 15, I think what comes is we've gone towards, imagine in veno arterial ECMO, we've tried closing the chest partially and then waking them up, not giving them muscle relaxants, going deep on sedation like morphine and dexmed, as we spoke before. And in some children, like who are between 10 and 25, the adult surgeons help us even cannulate centrally and tunnel the lines. Those end up even getting extubated, especially the ones waiting for another heart or something else. So these things can be done, but it's much difficult. But there are the children who have a neck cannula, transcervical cannula. If the lungs allow you, they can be extubated and they can be fed orally also. But if they're on a respiratory run, then like a CDH or a meconium, which is very short, but for CDH, then they need to be ventilated. So those are the challenges you have in children. But definitely every day trying to think whether you could not mobilize, but lighten the sedation so they can at least, mobilization just doesn't mean that they should walk. Just turning them on the bed and preventing a head sore, which is quite a common thing in children. And then bed sores are less, but the head sore is very common in children. Preventing that itself can go a long way.
Very nicely summed up, Rian. I think something that we started to do is early nutrition. You pointed it out the same way, not just preventing the bed sores, but also starting nutrition in time. Because if you build up the protein deficiency that we see in our kind of children that come to our center, they're protoplasmically very weak in proteins and albumin as well as chloride. So if you give the right nutrition, early nutrition at the right time, that itself is a mobilization. And you summed up the entire things very well. Thank you all from our side, and thank you, Dr.
Pradeep, I wanted to know whether you prone patients who are on ECMO, and what is your take on awake ECMO?
Sir, for the first question, during the COVID time, we proned patients on ECMO, sir. But after the COVID surge, we don't routinely prone patients. We didn't quite see any benefit or any sort of improvement in the aeration, and also the signal from the most recent prone ECMO studies from France. We don't prone patients on ECMO. And the second one, awake ECMO, yes, we do. I think any sort of ECMO that requires more than a couple of weeks, we try and get them to rehabilitate quickly in bed exercises, cycling exercises, and we try and move them around in the unit. But whether we do that before we start mechanical ventilation, we've done a few patients, but not many. I can recall a patient who was awaiting a lung transplant. We did a Avalon on her as a bridge to a transplant because she was developing hypercapnic respiratory failure, but not on a regular basis, sir.
Thank you for that. Himal, you want to say something?
So yeah, thanks, sir. I think you already closed the questions, especially about the proning I wanted to ask. One thing is we are also more prone towards early tracheostomy, so it helps us to come down on all the sedation requirement and also to mobilize them a little more aggressively. And also before this thrombocytopenia, everything sets in, that has helped us a bit. So that's one comment I wanted to put it across. So.
Well taken.
And Dr. Pradeep, one last thing. Sorry, I'm. So in
No
case if
problem.
the so when do you time your recruitment of the lung? Like when do you know this lung is ready for a little bit of recruitment so that you can wean off the ECMO a bit earlier in them? How early we can do that. That's the challenge every time we face. Is should we really go upon these ventilation measures? When is the right time? You think in viral pneumonia or ERDS, for example?
So it's sometimes difficult, sometimes easy, I should say, Dr. Himar. So what I tend to use, and a few of most of my colleagues tend to do, is to monitor the compliance during the journey in ECMO and on imaging. And imaging, if we see more aeration and we see the more compliance improving, then we tend to recruit the lung. We don't have a strict recruitment protocol, but we gently increase the ventilation, and we use APRV and pressure control, making sure that we achieve lung protective targets with a driving pressure less than 15 and plug to less than 30. And if we can sustain with that, and that's reasonable spontaneous efforts as well, then we go on to the weaning protocol with a 100% challenge test, followed by the deoxy and a carbon dioxide challenge test. But I have to say, it sometimes hit and miss. Sometimes we win, sometimes we don't. Sometimes patience is the game. Yeah, I mean, our traditional flu run is about 10 days.
Yeah.
And most of our ECMO runs are less than or equal to 2 weeks. It's the patients with interstitial lung disease whom we really get stuck with. There's one in our unit at the moment, and we have no way to move. Pretty stuck on ECMO, and sadly, these patients don't do well.
Yeah, very well said. I got the point. Thank you.
So thank you all, and thank you, Muralidhar sir, for, I think we had good discussions. We overshot the time. Apologies for that. But I would want to thank all the speakers. Each one of them was brilliant. And I think such kind of webinars from ICA is a treat, not just to us, the ECMO intensivists, but also to the students. I hope there was a good take home for them. Thank you for this opportunity. And thank you to all four of you for joining us at a very, very crucial time to you in your hectic schedules. Thank you, Pradeep.
Thank you, ma'am.
Thanks a lot. Thank you.
Thank you, Dr.
Vivek.
Murli, for opportunity. Thanks a lot. Good night.
Thank you, Vivek. Thank you, Himal. Thank you, Rian. And most of all, thank you, Clarnet and Dr. Muralidhar.
Thank you, sir. Thank you, madam.
Thank you. On behalf of ICA, I would like to thank all of you. Poonam Malhotra, Vivek Gupta, Himal Dev, Vivek, Kiran, Yatin, and Pradeep. And thank you so much. And it was a lovely session. I learned a lot from the session, and I hope you'll join us in the future educational activities too. And with that, I would like to conclude this session. And please do join us for the Sunday breakfast sessions on perioperative and critical care echocardiography. Thank you so much, and good luck.